In my conversation with Dr. Fernando Mirachi, he said something that shocked me. He said, "We get sued now for saving a life." What is the story with modern medicine? Dr. Mirachi tells his story. Fred, welcome to Bump in the Road. If you would, tell us your story.
So my story is not really a great story. It tends to be a nightmare, but so I was basically back in graduating from med school and I started my internship and I remember it. It was an evening shift. I'm in the ICU and I was taking care of a 55-year-old lady. She was admitted with a heart attack. So I was really geared up and amped up. She has a heart attack and I'm like, oh, this is really cool stuff, right? So I happened to just be in the ICU, just looking at somebody else, and then out of the corner of my eye, I see something happening, and I see the monitor going off, and she's going into what we call VFib, which is cardiac arrest. Okay, so I'm like now I'm geeked up. I'm this super excited intern. It's like 1997 or 1998, and I run charging to her bed with the old-fashioned defibrillator paddles. Right, I got the machine, and I'm gelling them up. And I have this nurse screaming at me at the top of her lungs. And she's screaming and flashing this yellow paper in front of me, screaming, "She's a DNR, don't shock her. She's a DNR, don't shock her." And I got paralyzed. I mean, literally to the tune, I had no idea what to do. I was in shock. And the patient, was lucky because there happened to be a cardiologist in the ICU at the time and he saw what was happening. He ran over, threw me aside, literally like picked me up, chucked me aside, took the old-fashioned paddle, shocked her chest. She woke up. She was talking to us. Back then, we were utilizing clot busters, so we gave her some streptokinase, treated her heart attack. She went home 3 days later alive. No deficits, alive. Had that been me alone, she'd be dead. You and kind of fast forwarding that, it was the last night of my emergency medicine residency. This is the tail end of my story. It really kind of whacked me out now. So taking care of this gentleman, they rush him in from paramedics. Nobody with him, just the paramedics, and they hand me a living will. And it's this guy, he's like in his mid-60s or so, and he's unresponsive, and you can feel he's hot, he's septic, from some infection or so. And I'm like, well, I'm not going to make this mistake again. So I get him in, the trauma bay, and I resuscitate the heck out of him. We put lines in him, stick him on a ventilator. About an hour later, his poor little old wife came in, very frail, and she said he was in hospice because he had end-stage prostate cancer, and she just couldn't take care of him at home, and he really just wanted to die, and he needed some help. So I made two mistakes. I totally screwed up and almost killed a 55-year-old lady. I over resuscitated a 65-year-old person who wanted to die naturally. And I got frazzled. I'm like, man, this really stinks. This is my last night of my residency. I'm starting, as an attending the next day at, then Hammett Medical Center. I was just bewildered as far as what was happening. And then I kind of figured, I'm like, I was a pretty good resident, I was pretty good resident physician. I was very academic, very clinical. And if I was screwing this up, then a lot of people had to be screwing this up. So my residency director at the time, he goes, "Man, you should write a book about this." And I said, really didn't think too much about it. But then I wrote a book. And then when I wrote the book, it did well, but people told me I had no research. So I'm like, oh, great. Now I got to do research. So we were part of a residency program at the time. We built an emergency medicine residency program from scratch, required to do research. So then we started doing research. And lo and behold, we published 13 studies on this topic. And, each time it just reproduced itself. Like the same issues kept coming forward. We don't know what these documents mean. We misinterpret them. We don't really know what the patient wants, and we're making guesses on people. And guess what? We're committing a lot of medical errors. And people die. People die or they get kept alive despite their wish. So either way, they're medical errors, and we don't really talk about them, and we kind of hush them under the carpet and just say we call them confusions, because at this point in time, we really want people to have advanced directives, but we really don't want to tell people the truth behind them and that they're actually pretty dangerous. And we got to do things better with them to make them safer for patients.
How are they
So that's my
dangerous?
story.
Well, how specifically are these advanced directives dangerous?
So they're documents, right? They're
Hmm.
based documents, and who makes them? Attorneys. And who interprets them? Doctors. And interpretation is really a guess, you know. We take a look at them. We look at the clinical scenario. If you can't talk to us, we make a guess. And sometimes some doctors don't even take the time to ask you. They just make a guess and think they're doing the right thing for you. So that's how they're harmful. They tend to cause people to die, or they tend to cause people to be overtreated and kept alive when they wanted to die naturally.
Boy,
Um,
the gap between the legal and medical profession sounds like the lawyers are just drumming up business for themselves.
well, it's part of their workflow, right?
Yeah.
They state planning attorneys, so their typical package that you get when you go see them. You get a will, you get a financial power of attorney, and then you get a living will, and you get a healthcare power of attorney, and you also get them telling you that this document's never going to come into play ever. It's never going to come into play unless you're terminally ill and they can't do anything else for you. And that's a bunch of bunk. That isn't true. Anytime those documents come into play, they change the clinical mindset of the individual taking care of you. And it's up to you or them to really clarify what the intention is of that document. And if you don't do that, you run a risk. And then you get your bill from your attorney, right? You get your couple $1,000 bill for that estate plan.
So what's the solution?
So, through research, we've figured out that you can do better, right? We're in the world of tech, in medicine. We do great with tech when it comes to saving your life. We're horrible with tech when it comes to medical record documentation and workflows and that kind of stuff. I mean, we're backdated. We're antiquated. We're in the 21st century now, and we're still using paper at some point in time. We're digitized paper, and we're putting it into workflows. So the solution really is to figure out multiple things. We got to do better at finding out what the patient wants, right? And we have to do better at educating patients in a non-biasing way as far as, their choices. The education that exists out there for patients is very negative. Okay. It's propagated by a group, and the group is often the payer group because they want to essentially, maximize profits, diminish overutilization of resources, and so on. So in the advanced care planning world, it's very negatively expressed education, right? They'll walk up to you and try and talk you out of CPR treatment. They'll say, hey, we're going to break your ribs, we're going to puncture your lungs, we're going to tear your esophagus. Well, that'll scare anybody, right? But in the right setting, you would have a trade-off in a heart attack like that 55-year-old lady that, if I broke her rib and I got her home with her family and she had no deficits, I think she'd be pretty happy, right? And she was happy, right? So we got to do better at the education in a non-biasing way. We got to do better with the tools that we use, right? We need better tools than paper to essentially kind of give us an idea of what the patient wants. Yeah, you can tell us what you want, and if you're in a terminal condition or persistent vegetative state, but terminal condition is pretty vague, right? A UTI could be terminal in the right population. You take an 85-year-old male or female patient who's got, who gets a urinary tract infection, who gets bacteremic from that urinary tract infection. Oftentimes we give them IV antibiotics and fluids, and they, get better within 24, 36 hours, and they go home. If you look at a document and think, oh, this person's septic, they're 85, they got a 20% mortality or 30% mortality, maybe we shouldn't do this. Well, that's a broken issue right there. It's like I said, we got to get better at figuring out the tools and essentially how to better understand what you or the patient wants as far as their treatment, right? Sorry, let me close that thing. I don't understand why it keeps coming on. There it is. It's silenced down. So, but we got to do better with the tools to make sure that we understand what people want. And there's a way to do that. You don't have to just settle for paper anymore. I mean, again, we have technologies, right? One of the studies that we did was a triad 8 study. And I got the idea from it because I'm literally sitting there watching Superman with my son at the time. This is years ago. And I'm watching Superman with him. And Clark Kent, he gets kind of bewildered and he has to go get some advice, right? So he walks to whatever the cold area that he went to was. He went to his crystal cave that was created by his family. He puts a crystal inside like one of the devices they had, and up came his mother and father talking to him. And it just kind of hit me right then and there as far as being able to use what we call patient to clinician video. We use a lot of video in medicine to get people to make decisions, right? But we don't use patient to clinician video to help us make decisions for you. And it just seemed like a pretty novel approach to do it. So then we figured out ways to do it utilizing smartphones and QR codes, and we put it into research. And guess what? In research, we found that when we compared that process and technology to figure out what a patient wants, that we can get almost 99.8% accurate as far as what they want. And the only little change there is because maybe the physician or provider at the time might have some differentiating opinion as far as what they think versus what the patient's describing in the video. So we figured out we could do it better. And through that, we actually started to put it into clinical practice. It was around 2017. Medicare at that point in time came out with saying they're going to pay for advanced care planning. It was at the time when the triad 8 study was closing. We had all the data from it. So we wanted to put it in the clinical practice. So I took some time away from emergency medicine, or actually, I don't really call it time away. I just added time to my day to take care of patients and do advanced care planning. And we showed that we could actually do it. We can get people to actually record videos, because people would often tell me that no, people will never do that. It's too intimidating. They wouldn't want to record a video about how they want to be treated. No, sure they do. They actually do, and they prefer it. So we did it in clinical practice. And then I took all that data to my bosses at UPMC at the time, and said, hey, this is really cool stuff. I think we can build a practice out of this. You're like, yeah, but then you can't scale it. So then at that point in time, we took time away again and essentially hired, what do you call them, software developers and writers. And I
Hmm.
met with them day in and day out. And essentially we started to put together the initial aspects and concepts of what we called video, which is patient to clinician video. So at that point in time, again, we showed it could work. And then I took it back to that same palliative leadership at UPMC at the time and said, look, we can now scale this. We got software, we can do this. We got insurance companies that'll pay for it now. And at that point in time, I was told something that wasn't very positive, and it was to the line of, kid, if we do what you want to do, too many people would live. And I was like, whoa, that was a
Whoa.
little annoying. Yeah. So at that point in time, I realized it's not the right place for me, and that I was going to step away and look to the right group to figure out how to build this externally and do it. And that's when I joined US Acute Care Solutions. And US Acute Care Solutions is a large, acute care medical practice of physicians. They do emergency medicine and hospitalist medicine. And they saw what this was. They figured it was a very good thing to have for patients. And we've been developing it ever since.
I want to go back to your comment that too many people will live.
Mhm.
Did the data actually show that? Were people more inclined to want to be kept alive for a long period of time, or were they more inclined to want to go a natural death?
Yeah. So it was kind of like, it was more the opposite, right? People want to live when they have a very good quality of life.
Hmm.
They don't necessarily want to live when they don't have a good quality of life. And that's what we were finding out. We were finding out that patients essentially wanted a way to better express themselves so that people wouldn't screw up in their care. But when it was time, they were more than willing to allow a natural dying process. Now, I will say this, and this scared the heck out of me, quite frankly. We did a triad 12 study, and it was at my own host institution where we evaluated people that came in with existing do not resuscitate and these fancy medical orders called physician's orders for life sustaining treatment. excuse me, and we essentially went up to them with a tool to evaluate if they knew what they had in place. If they even knew that it was in place. We actually found that 25% of people had no idea they even had a do not resuscitate order in their medical records, which was very surprising to some people. And then we found that of the people that were truly terminally ill, right? They were there, they were being admitted with a complication, but they were terminal. They knew they were dying within 6 months to a year. And we asked them, you have this do not resuscitate order now, and you're even in palliation, and you have all these comfort care orders that exist here. So you're admitted to the hospital, you're here, you're admitted, whatever the condition was. Some people were admitted with pneumonia, some UTI, some wound infections. And we asked them plainly, we said, if something were to happen here today, would you want us to do things to save your life? Would you want us to do fluids? Would you want us to do IV antibiotics? Would you want us to do CPR? And about 60% of them actually even wanted CPR at the time. If it would give them a chance to actually have a period of time where they needed to settle something else, like a conflict or some issue that they wanted to do, see a grandchild graduate or be born. There were so many different reasons for it. And it really scared me because there are so many people I've actually let die because they had those orders in place, right? They had those orders in place, and we didn't ask them, would you like us to try and temporize things to save your life? Or are you okay at this point in time if we just allow you to die naturally? I've had a lot of different enlightening things that happen, and I hear this all the time. Like, people get mad when you save their life. People who want to die get mad when you save their life. And I've taken care of a lot of people. I've resuscitated many. I've allowed many to die. I've sent people home in hospice care from an emergency department, which is kind of unheard of for an emergency department physician. But each and every one of them that I've resuscitated, that I had an opportunity to go back and talk to and ask, hey, did I do the right thing for you? Right? I've never had one person actually tell me they were mad at me for saving their life. Not once, you know? And everybody's going to get that chance to die, right? It's going to happen. Like, even though like we treated your UTI or pneumonia today, something else is going to happen if you have a condition or you're prone to it that's going to take your life eventually. But again, I've never really had anybody whose life I saved get pissed off that I actually saved their life. So there was just a lot of different things that happen along the way in the studies that really kind of wake my mind up to certain things, but they all come back to the same thing. We need to do better. Like, we need to do better for patients. We got to get better at actually informing patients. We got to be willing to actually listen to them. Like, you have to listen to a patient. Like, I can't tell you how many times I got calls from doctors, who were taking care of patients, were mad that I put their patient on a ventilator or so on because they had a document. And I'm like, well, your patient told me to do it. So they trump any document, right? Like, they rule. They have the power. The power is in the patient's voice. If they tell me they want to be intubated and go on a ventilator, guess what? That's their right, and I'm going to put them on a ventilator. And I can't tell you the backlash that physicians get over time, over the years, especially who do resuscitative medicine, from physicians that essentially think they did it right for the patient, right? If you do it right for the patient, you have to listen to them. You have to listen to the patient, and you got to be willing to accept at times that they're going to want things that you don't agree with.
There are two components here that I want you to talk about. One is the patient video and how that entire system works. And the second part of it is, how do you get doctors to be aware of this video and to listen to it?
So, well, let's go by one. So we'll take the process of the video itself. So what we do, and we do it one of two ways. So, for the young and healthy population, we created this do-it-yourself process to do this because people are young, tech savvy, and so on. And, oftentimes they're just busy and they just want to check a box that they did something. But we do it in a way where I think it's at least better than what exists today. Okay, so you go through a process with the software, and essentially you populate all your demographic information. You have to go through education, and what I call a non-biasing education. Again, something that's going to be middle of the road, that's going to speak the risks and benefits of accepting or declining these types of treatments. Okay, and then it'll essentially take your choices and information and populate a prescription for you that you read into video. And that is what we call as a prescription for advanced care planning. And we give them one choice. In the do-it-yourself version, you get one choice. It's a full code choice, meaning you're going to accept all forms of treatment to save your life. The reason we do it like that is because if you're going to start to decline forms of treatment, we really think you need to speak with someone who's educated and trained to be able to explain those risks and benefits of declining those forms of treatment. Okay, so those people who want anything other than the most aggressive form of treatment, we take them through the physician process. And that's a process where you get seen by a physician, you get a medical evaluation, you get risk stratification, you get prescribed or you get some recommendations as far as what to put into video. And it's based on your treatment choice. So if a COPD or somebody with lung disease doesn't want to be on a ventilator, we talk to them about it and find out what their issue is as far as being on a ventilator. And most of the times they're fearful of the very prolonged treatment where they wouldn't get off a ventilator, not the initial aspects of treatment. So through that, we're able to make sure that they understand that you don't really want to decline ventilation or intubation or those life-saving forms of treatment. You just want to regulate it. You want to put stipulations in there that you want to try the non-invasive forms first. And then if that doesn't work, then you go towards the invasive forms of treatment, but you don't want to continue with those invasive forms forever. And you put parameters on it for when it should stop or when they should try to de-escalate it. So you get two ways to do it with us. One, again, do it yourself, and one through a physician. Either way, you come out with a video. And those videos can be aggressive types of videos, or they could be end of life types of videos, or they could be things in the middle, but they actually have the ability to be customized to what your needs are. And that's been a really cool thing. And we found that to be very, very informative and even beneficial. To the second point that you asked about, as far as how do we make sure that they get seen and will physicians review them? So our physician feedback with them, I'll take it in reverse. The physician feedback's been very good. You know, most of the physicians that look at it and review the videos think, wow, you know, it's just so much better than looking at a living will or an advanced directive or guessing on a DNR order and so on. Now, to make sure that they're available is something else. We kind of train our patients and their agents. And I hate to say it like train them, but it is. We get them ingrained to listen for words. Anytime they're asked, how do you want treated in cardiac arrest? Anytime you're asked, do you have an advanced directive? We really don't even want them answering the question, because the way they answer that question sometimes results in an inappropriate do not resuscitate order being entered into their records. So we actually just asked them to pull out their ID cards at that point in time to show the individual talking to him what is on the ID cards. And the ID cards has basic information on them, and then it has an ability to pull up that video from a QR code. So the other things that we do are multifold and try and look to capture different areas of where that information should exist, right? So when we see a patient, we take the consult and we send a copy of the consult and the output as far as the video ID card, a paper version of it as well, to their primary care physician, to their estate planning, to their attorney, and to their hospital medical record department that they designate as a hospital that they would attend, just so we can kind of different areas. And then we kind of keep things on our patients. So we make sure that the patient themselves has an ID card. We make sure that the healthcare agent that's appointed by the patient has a copy of the ID card. We make sure they have, in case of emergency, magnets on their refrigerator for paramedics to see when they come in the hospital, because we train paramedics to look there on the sides of refrigerators. We make sure that they have window decals for their car for the paramedics as well, because the paramedics are trained to look for yellow dots on the back of windows and so on, depending on the state they're in, to look for vital information on the patient. And then the really cool stuff that we're doing now with tech, again, is to make it more available, is through different forms of technological enhancements with Apple. So the iPhone. So now we're able to get it into the Apple Wallet. We're able to use widgets on those wallets to make sure it comes up on the lock screen. We're able to use widgets and your Apple CarPlay now to make sure that it exists on your Apple CarPlay screen. So more and more that we look to do this, you have to do what you think is right, but then you also have to look to, will it be available? And that's been our whole process. So we continually are always looking at what we do in the medical practice as far as what, and then also what we do on the fulfillment end to make sure that what we do for patients is getting where it needs to so that it'll get seen.
How has the legal profession been open to this?
So we get a, the legal profession is funny. So there's something called the Uniform Healthcare Decisions Act, right? And I think it was in the end of 2024, they all met and made these recommendations that, you can keep doing paper, but you also have to start looking to digital processes for advanced directives. And they made a recommendation that, states would adopt it. And some states did, some states didn't. But in the end, most of the attorneys that see what we do, they're very happy with it because they've also had the concern that maybe what they're doing isn't the safest thing that is actually being done for patients. Now, there are some states, and I will tell you, there are some rigid states, like Ohio being one of them, which is on my border here. And we continually get there are attorneys from like the Cleveland Clinic Foundation, and mind you, I'm sending my patients there, right, to be treated, right? But the Cleveland Clinic Foundation, there's another health system, it eludes me right now, but they are so adamant that it doesn't meet Ohio standards, and Ohio standards means it needs to be in paper, and we try and inform them that actually it does meet Ohio standards, because it's video and paper and you're getting the best of both worlds. And because they have this perception that it's a video, they're just so agnostic to the fact that it's meeting the compliances. And they often at times will try and get our patients to sign other documents. And I tell my patients just refuse. They can't force you. They can't not treat you because you didn't sign their hospital form as far as, their advanced directive. It's against the law. So that's my attorney answer. I have attorneys that love what we do, and I have attorneys in certain areas that are, yep, it doesn't comply. So, we're not going to honor it.
I think the thing that strikes me so much about this is that it really humanizes that patient to doctor connection in a
Yep,
circumstance where you may not have that opportunity.
yep, sure does. And that's what we really like about it too. Because again, patient to clinician, I mean, that's a big thing that's missing in a lot of what we do as far as medical care.
Do you have an ID card on you by any chance?
I do. I do. I might have to take
Yeah,
my
no,
screen.
oh, I can see that.
Yep,
So
that's
people just
fine.
scan the QR code and that brings up not only the documentation, but the video of the person actually talking.
Yep, absolutely. So what happens is well, so the ID card itself, again, it'll have information on it. You see the text information, name, photo, date of birth. So it meets what we call the Joint Commission compliances, actually exceeds the compliances. And then it has information that we use based off a mnemonic called code that I came up with that essentially speaks to their code status, their stance on organ donation, because we screw that up a lot, directives that they may have, any emergency contacts or appointed agents, and then if they have a post or most or some form of special medical order that needs to be addressed quickly. And then it'll have a QR code. The first QR code on the front actually pulls up the video. And then the back of the card actually has all the different signatures, the patient signatures, any witnessing signatures, because some states require two and some require one, but it also then has a physician signature. And then it has another QR code to all those paper-based documents that all the legal beagles want.
Could you bring up that card again? I think I have a question about it.
Yeah, sure. How do I
There,
hold
there.
this?
Oops, oh, got it. Okay, can that integrate like with your Medicare card?
Yeah, well, so that's what we're hoping at some point in time in the future. So in the future, we're hoping that insurance companies will get it on the back of the ID card or the back
Hmm.
of their either Medicare or ID card for the insurance company. And the same with driver's licenses. Now, some states actually do allow it to go on the driver's licenses. Some states have laws that say they have to put it on the driver's license, but they haven't figured it out yet. But in the end, I guess it's very difficult to change what Medicare does. I guess even the paper aspect of the Medicare card, I mean, technically it's illegal to even laminate that paper-based card, and there was a number of different congressional studies that looked at taking that paper away and making it a plastic ID card like a credit card. and it just never came through to fruition. I guess it was too problematic for whatever reason they felt that Medicare could not do it.
Oh, that's interesting. Lots of questions about that one. But having, let's not go there.
Well,
Uh,
government shut down, so who knows?
yeah. Maybe we're just going to revamp the whole system and this is the opening. That would not be all bad. Out of all this, what are some of the pieces of wisdom that you walk away with?
Oh, well, so there's many, right? There's wisdom for patients, there's wisdom for doctors, there's wisdom for, I guess, developers and so on. On the developer side, if you have a thought process and you think you're doing something better for patients, I tell people who get into spaces and start companies and so on, look, stick to your morals. Like I could have easily folded, right? When that guy said to me, "Hey, you're going to keep too many people alive," I could have like, I don't know, I could have aligned with him. I didn't. It wasn't the right thing to do. Right. So, stuck to my morals, and like you're going to come across people that are going to be so negative, and you just have to keep working around them. Don't even waste your time going through them, because you're going to expend too much energy. Go around them, find like people, work with like people. To patients, I tell patients that they really need to figure out someone they can trust between doctors, between agents, between family. I mean, look at the elderly population right now. There is such a growing number of people right now that'll end up in an emergency room,
Yep.
you know, with no one. And I have some patients that are like this. They have no one. They don't really have many friends. They don't have family. They outlive their family. I oftentimes get asked to be their decision maker. And there's a line I have to kind of stand on that, if I'm your doctor, really shouldn't be your decision maker too, right? But I'll help any clinical person at a time of need when it comes to any of my patients, but I really shouldn't be that decision maker. But there are a lot of people that want to take advantage of that elderly population, right? The scammers and everything else that's out there. So I try and get people to realize on the patient front that they have to find a niche of people to be like friendly with and support each other. And it's almost like a community that they need to have. And one point in time, I had this group of about 8 women that were all retired, all alone because their spouses had passed away. And they all would keep together. Some of them lived with each other just because they wanted to like downsize and so on. But they all connected with each other to make sure they were all there to support each other, right? If one got hospitalized, they all knew about it and they all came to that person's aid and so on. And I think that's a piece of wisdom that I think the elderly population needs to become aware of pretty quickly. And then for doctors, I tell doctors all the time, you have to do what you think is right as far as taking care of a patient. Don't let a form bias your decision making. If you know there's something right to do, you do it and you document why you did it. Now, to that end, we're starting to be challenged with that. Like we get sued now for saving a life. Like that's never been heard of. But in the last, say, 7 years or so, that number of cases has blown up pretty exponentially. As far as like, somebody comes in with a document and you save their life, guess what? Their family gets pissed off now. They're taking the estate money, they have to pay for a nursing home. All of a sudden, that family's now angry and they're suing doctors because we saved that life. But I still come back to the point that doctors need to do what's right for the patient. And that's really where you have to hang your hat. It's not a perfect world. We knew that going into medicine. It's not a perfect world. And we would get sued. But in the end, you still have to do what you think is right for the patient.
Do some of these updates need to be revisited, particularly as you look at an aging population, the 8 women, for example? What if
Yep.
some of them die?
Yep. Great question. So that's why we made it a medical practice because a lot of what lawyers do, it's one and done, right? You
Yeah.
get your estate plan or you did your advance directive. Now you got to die, quite frankly, before anybody sees them again, right? Because that's when your estate goes into probate and they got to do all that other stuff and separate all the assets and everything. So what we do is we risk stratify people to come back, right? So we'll have people that are young and healthy, and we tell them don't come back for 10 years unless something happens. We have people that are in their 80s and will have come back every year. We have some people that are in the active phases of dying, and we see them one way, shape, or form monthly or every 2 weeks, just depending on what that patient's need is. So that's the best way to do it. We risk stratify people to come back. And then with our existing patient population, we usually tell people that if you're discharged from a hospital, then we want to see you. If you have a big elective procedure coming up, like a bypass or something, we want to see you. And we make it so that we build relationships with patients that way too.
And these relationships are between Midio and the patient in that
The
case.
Midio Health, our medical practice, and the
Mhm.
patient. And then Midio is a technology that we utilize in that practice.
Okay, got it. So you're really asking physicians to step up to the plate on a human level, big time.
Yeah, the first thing is they have to realize there's an issue, right? A lot of them don't even know they're doing wrong. Because like when you put out research, oftentimes it takes about 17 years. Okay, and this number was staggering. It's 15 to 17 years to really make that kind of a change, and that's a lot. But interestingly, like when we come out with research that speaks to treatment, like a stent, it gets adopted quickly, right? Like cardiac stents, I remember when the first cardiac stent came out. I mean, it was a really cool thing, and every cardiologist wanted to do them. They had new technology they could use. So it was a really cool thing, and it got adopted very quickly. But when we talk to physicians about doing things better, where they might be doing wrong, or maybe their opinion's a little bit different than what we're talking about, then it takes a lot longer.
That's interesting. I think part of it is within any profession, when you get used to doing something again and again and again, you kind of develop a streamlined process for getting it done.
Oh
Obviously,
yeah,
there are decisions to be made along the way and whatnot. But once people get into that behavioral rut, if you will, it's very hard to convince them that there may be a better way to do things.
sure is. Yep. Plus, they have to admit, right? They got to admit that they might not be doing it exactly right.
Although I would say these days everything changes so quickly, particularly with regard to technology, that you have to train yourself to be adaptable, like it
Yeah.
or not.
Yep. Absolutely. It's funny. I remember every so many years we change over with EMR systems, right? And I remember when we changed over from one of my favorite EMR systems to one that was not so great, and just the amount of work that went into it. I'll just put my head down and just keep running and going through everything and so on. Then at the end of my shift, I had all these charts I had to do because I didn't even bother using the system at all.
You were suddenly convinced, right?
Oh, I got convinced real quick when I had to spend a couple extra hours doing paperwork, or not paperwork, but computer work. I'm like, ugh.
So, what are your plans for this process and technology moving ahead, say over the next 3 to 5 years?
Yeah, so my goal is to really get it to become ubiquitous. Like you need adopters. You need the groups to adopt, like the law profession. You need the medical profession to adopt. It has to become the, I guess, the analog to it, right? You can still have your document, but you still need a safeguard. That's the thing that's missing. Midio is our first safeguard in this space, in my opinion. Because we have medical orders, we have advanced directives, we have palliative care doctors, we have ICU doctors, we have all these people that can kind of get conflicted at points in time. But you need something to clarify what the intention of the patient is. So that's the safeguard. So my goal is that anybody that has an advanced directive, anybody that has a do not resuscitate order, or anybody that has a post order, get this as a carry along to clarify what their true intentions are. And we're going to make it so that it becomes affordable to people. I didn't do this to make money. I know the company people don't really like to hear that, but my goal is to make it a better place. It's up to them how to make money with it. But my goal is to make it so that whatever system wants to use it, we make it available for that system to utilize. Whatever attorneys want to use it, we're going to make it available for those attorneys to utilize. My goal with attorneys really is to build relationships and practice relationships so that attorneys can actually align with doctors so that they can do the law aspect, the doctors can do the medical aspect, and just come together and do what's right for the patient. But that's my goal over the next 3 to 5 years. I got to wake up the community. I got to wake up the systems and make it so that what we've done initially with this, as far as our initial patient base and practices, can now get taught to everybody.
Well, I want to have you back in 3 years and revisit this because I think that this bridge between humanity and medicine is something that's really missing in our system, and both sides of the equation need it.
Well, it's a date, 3 years. What's the date? November 6th, 2028.
All right, I'll jot it down and put it on my calendar.